I took the time, originally to go train at the University of Cincinnati in emergency medicine. Great training, great program. And then, years later, given the opioid crisis hitting our community, decided I needed to do something a little different and sought experience and training in addiction, and ended up getting board certified in that. The long and short of it is actually pretty simple. As a physician, you take an oath to do no harm and to treat patients as best you possibly can. And in the environment I was working at the University of Cincinnati, as well as Jewish Hospital here in Cincinnati, we really didn't have any resources or good evidence-based, readily accessible resources for patients with opioid overdose and all the consequences related to that. So out of frustration and duty to the field, we undertook the development of the first clinic in Cincinnati years ago, with some core concepts which we've held true to this day. And those are pretty simple. It's really follow the science and the evidence to treat patients, which I'm bound to do by oath, and then also be nice, compassionate, and accessible. And lastly, meet people where they're at as fast as we can. And so those are a few of the core concepts that we've stuck to as part of our mission and vision to grow those services across the states of Ohio and now Kentucky. Really never thought we would get to the scope and size and the impact that we have been able to do in the past few years, but very proud of that, very happy and humble to continue to do those things. And I'll let Dr. Kang and Nate Pelletier introduce themselves briefly, who I've been very blessed to have come on the team in the past 2 years.
Thanks, Dr. Ryan. Good afternoon, everybody. Thank you for joining us. I'm Nav Kang. I'm a psychologist by training. I've been with Brightview for a little over a year now as a chief clinical officer. Prior to coming to Brightview, I was with Mercy Health, a large health system. We did some pretty cool work when it came to taking care of patients on the hospital side and in the emergency room who had severe and persistent mental illness. And we did some innovative things around integrating psychologists and psychiatrists into the primary care setting. But what we found was that we had very little capability when it came to treating patients with substance use disorder. And frankly, even like what language to use and as Dr. Ryan alluded to, how to treat folks with dignity and with respect and understand addiction as a disease. So had the opportunity over the last several years to collaborate with Dr. Ryan and others on the Brightview team and to understand, what a care continuum could look like, how a hospital can participate in that. And so when the opportunity came up to join the team here and just go deeper with the addiction treatment work, it was hard to pass up. So very fortunate to be on the team and to be able to speak with you all today.
Yeah, thank you. I'm Nate Pelletier, Vice President of Development Initiatives for Brightview. I think my pathway was probably not as linear as Dr. Ryan's and Dr. Kang was through addiction. Yeah, maybe see through my bio a bit. But prior to coming to Brightview, I was an executive director of a nonprofit agency that served veterans and homeless veterans, and we realized that in 2013 that the priority in I think the driving challenge between their social challenges and recovery was their addiction, not just their homelessness. So I went on a robust mission to turn our agency from a homeless agency into a clinical addiction agency that's providing housing for veterans. And I can tell you, Dr. Ryan and Dr. Kang, as I engaged in this process, we're right there, and I think experts leading the way that were inspiring and helped guide me on that way. And I also like to say that when you're in this industry and if you're doing good things, Dr. Ryan finds a way to snag you. And I ended up at Brightview in 2018 to continue the work in this industry and to really focus on being able to take just the work we did in Hamilton County, but to use the great platform Brightview has to go across multiple sites and multiple communities to find great ways to improve our services and to reach out to the population that we serve that are suffering from substance abuse. Main focus I have right now in the company, and probably the basis for this call in this forum, is to discuss what we're doing, particularly to serve our criminal justice involved patients. So I look forward to discussing that with you throughout the dialogue and in the forum.
So I'll speak a little bit to this slide about our commitment, about what we're doing. We sometimes have different folks speak to different issues on these forums, but I feel that I can address this well. At our core, what we do every day, all day, and we do a lot of things in the field and education and research and all this other stuff that we're not going to talk about a ton today. But at our core, we're a holistic outpatient addiction treatment center. What that means is we have a full multidisciplinary team of physicians, nurse practitioners, psychologists, therapists, social workers, case managers, peer supporters, a whole team that delivers this 3-component model of treatment to patients with substance use disorder. Obviously the focus and the initiation of Brightview was around opioids, but that is by no means the only thing that we address. And that's actually not a very accurate representation of humans with substance use disorder, that there's, just opioids at the core. And so we focus on clinical research and best practices at all times, as I've said. And probably one of the most important things we do is really be available when people need help. When I started in the field, that was a foreign concept, and a lot of people told me there was no way you can do on-demand, addiction and treatment services. That's not a thing. I refuse to believe that for 2 reasons. Number one of which, I have an emergency medicine background, and we all believe in high-quality emergency care 24/7 in this country. At the same time, I also saw patients and knew that they couldn't wait often, and sometimes waiting was a fatal decision. So we really, at our core, do the things here at the top of the slide. And then just as important are the next 2 points and sub-points. The commitment to the community. I've been around a lot of states, a lot of Ohio. I'm born and raised in Lexington, Kentucky. Family from Eastern Kentucky, very familiar with the challenges across different metros and rural areas. We know that this disease impacts the community as broadly as anything that exists. I've unfortunately had family members and friends that suffer from this, as well as other complicated diseases like cancer. I've never seen another condition damage a family unit and community as much as addiction. So we really strive to collaborate with our partners to work on the community impact of addiction. I've over the years become pretty close, if you're familiar with Sam Quinones, who wrote Dreamland. My father-in-law's from Portsmouth, Ohio. And just knowing the depth and the breadth of damage that's done by this condition, we feel that community engagement, as you can see through these points, which include criminal justice, local boards, local coalitions, we know that those things are just as important as our core functionality. We're just a piece of the puzzle, and part of the team is how we see ourselves in each community. And I'll give an example of the things that we've been able to do over the past few years because of that commitment. We actually did the largest Narcan distribution in the United States as a part of a coalition with the University of Cincinnati and Hamilton County Public Health. I knew that was something that was lacking in its, I would say, scope and accuracy, meaning we weren't getting it where it needed to go to the right people at the right time. And so we spent a couple of years and a lot of money and time making sure that we could turn the tide here in Hamilton County, where I still practice. And so that was an example of how our community commitment can change, the paradigm. Lastly, I'll reinforce, like I said, we really do believe in 24/7 access as much as possible and have committed to that framework so that people can get help when they need it. We don't operate the treatment centers 24/7, but we do have access to get connected to treatment at that scale. And we do anything and everything to make sure that you can get in to see us as fast as possible. And speaking to the continuum of care for substance use disorder patients, I do a fair bit, and a lot of our executives and management do a fair bit of work on the field itself. So not just, it's for our patients, but not directly, impacting each individual. We know that there is a huge gap between what is currently being provided for patients and what needs to be provided. And that includes both any service, so whether it be IOP or inpatient, as well as development of that continuum, which we know is best case for patients. So we work very hard to do the parts that we do, which are parts 1 and 2 here that you see. We don't do residential and inpatient, but we do coordinate with those folks that provide those services. And we look at that like we do everything else at an evidence-based or scientific level, meaning we know that about 1 in 5 patients do need levels 3 and 4, but 4 out of 5 don't need that level of care. And so we strive to serve those members or take those members from the other partners as part of that continuum to really develop that. That continuum is present for basically every other disease, state, or condition in the country, and we feel like this shouldn't be any different, but we know that that's still the case in many communities. Just a few more points on this slide. I want to make sure we're clear. We do coordinate with detoxification or detox providers, but that service by and of itself cannot be done in a vacuum. Detoxification of alcohol or opioids, but opioids specifically by itself, and then no continuing care is very dangerous. And so we partner with those folks to make sure that there's a great handoff to a consistent and ongoing chronic care model, which is what we provide. And we do that, back to the point about access, readily available. So we make sure that if somebody is leaving some other treatment environment, which they may be best served in, that we are available to catch them when they're transitioning so that they're most safe and receiving the best treatment. I think I'll finish my section with this and let them move on to our other experts, and then I'll make sure we get a lot of time of questions. I've already talked a little bit about our focus on medical best practices and science-based care, and that is following the published evidence, the literature that is out there, and it's been out there for many, many decades. Unfortunately, we're, as a field, not particularly aligned with the evidence, which is getting better, but still has some room for optimization. I was fortunate enough to participate in the writing of the Surgeon General's report on drugs and alcohol, and meeting with him, and years ago providing input on these issues. And these points that you see here under the Surgeon General's report title are all things that we know are appropriately addressed or best addressed when medications for opioid use disorder are part of the treatment plan. That's not really up for debate, and it doesn't call out a very specific medication, but we do individualize each patient's treatment plan, of course, with the most appropriate medication for them. And that can include things that are not just for opioid use disorder, but obviously for other mental health conditions and whatnot. So it is a part of our program, but it is only a piece that we do provide and dispense in some locations different medications for patients. We strive very hard, and we are very blessed to have a huge network of board-certified addiction specialists. Most of us are double or triple boarded in different types of medicine. And I think it provides a unique perspective and experience for the patients that we have folks that have been doing this for so long with collectively hundreds of years of experience across our network of addiction specialists, and that we can make sure that we are determining the best medical component of the plan. And then Dr. Kang, of course, and the rest of his team round out the holistic treatment model that we deliver. But to finalize the points, most patients do better with medications as appropriate to their substance use disorder, and delivering those medications in a timely fashion is how we see patients best treated, not waiting to put them through misery or making them jump through too many hurdles so that we can address these issues. We do also make sure to be very specific that we are even accurate, not only on the type of medication, but dosing of medication. And we follow the science. So, people have different opinions about medication-assisted treatment. That's not really where we operate as an entity. Those of us, again, especially our medical practitioners, we're bound by both our oath as well as avoiding medical malpractice to ensure we're following best practices of medications, whether that be dosing, whether that be type, whether that be duration. So when folks give what I would describe as opinions on medications, I simply say I'm bound by duty to give the patient the thing that I know is best for their condition, and I don't really have another perspective or choice that I can put forward based on non-medical opinions. And so happy to, obviously that's a very complicated topic we're not going to cover all of today, but transparently we really are very specifically bound to making sure that we are accurately giving the patient the right type, duration, and dosage of medication for their condition. They're really, in any form, in any setting, we do appropriately address concerns about diversion. I know that's always something in the criminal justice setting that is a question. I personally actually consult for a large jail healthcare company that came to me years ago and said, hey, we want to do a lot better job of medication-assisted treatment or opioid use disorder treatment, or even broader mental health and substance use disorder in our network of jail healthcare. And they've spent years researching and putting forth those best practices throughout their network, which has been very impactful in reducing strain on the criminal justice system as well as mortality in the jail, which is a very unfortunate issue. But we know that those things happen. We know that some of the medications can be diverted or misused, and we have multiple strategies to address that, up to and including using injectable medications which can't be misused, and those are options as well. And we've even done if you don't know, there's even implants that you can do for some of these medications, and I've done those. We found those to be useful in some cases. So that goes back to that kind of core concept of this is why we hire very, very intensely and intentionally seek board certified docs and other experienced practitioners, because it's not as simple as this medication is the right one for everyone, or that dose is the right one for everyone, or anything like that. Just like every other disease state I've ever treated, these are humans that are complicated, and that's why we seek that level of experience to address their medication plan.
Thanks, Dr. Ryan. So similarly, on the other side of the house, as it were, on the clinical team, we look for folks who are pretty diverse in their backgrounds and skill sets. And so on the clinical team, we have social workers, counselors, we have case managers, we have peer recovery supporters, folks across the board who themselves have experience in treating substance use disorder and in treating folks with mental health conditions as well. I think one of the important things for us to note is that, our goal is to be able to meet obviously all of our patients' addiction treatment needs on an outpatient basis, but then also 90% of their mental health needs. And so our workforce is very well equipped in that regard. Over 90% of our counselors have a master's degree. And so very concretely, we have a very robust clinical program that brings together group therapy, individual counseling, couples and family therapy when available, obviously knowing that a lot of folks have burned bridges when they come to us. And so we look to reintegrate folks with their families to the best of our ability and at whatever pace is practical for each patient and for each family. When I talk about case management services, a lot of that is categorized under what we have here listed as social services. But at the beginning, this can be as simple as making sure a patient has a safe place to stay tonight and a way to get back to us the next day, because folks come to us oftentimes in such a state where they don't have easy answers to those kinds of things. In the short term, we might look at helping them get on insurance and making sure they have access to food and that kind of thing. But then certainly in the medium term and in the long term, we're working on resumes, we're working on job interview skills, we're working on getting folks reintegrated with community at a broader level. Along the way, and Nate will talk about this, folks from the justice system will obviously be interested in how patients are making progress, what type of attendance do they have with their clinical services, what do their toxicology results look like. And so, we have historically done that within the clinical team and have now built a specialized team specifically to relate to both the justice system in terms of probation and parole and with judges directly and also with CPS, so that we can make sure that reporting is predictable, it's comprehensive. Obviously, there's some implications around release of information and all that kind of stuff in the background. We can get into that detail if folks have questions on that. But in the end, if we have the ability to communicate with one another, then we should take that opportunity and use that to the best of our ability, because then we can truly collaborate on the needs of the folks that we mutually serve. So from a treatment standpoint, we offer all of those modalities of treatment that I talked about. We also do all of those things virtually now as well. We've been doing that for 2 years now, but certainly given the pandemic, as many others have, we have ramped up our telehealth services to a pretty significant degree. But what I'll tell you is we're not really working on telehealth from the standpoint of, how do we connect and what technology do we use and that kind of thing. We're really working on second order and third order problems when it comes to telehealth. In other words, just this morning, I met with the clinical team and we talked about what education are we disseminating to our clinicians around how to establish rapport with patients in this modality. When you're doing group therapy, how do we pace that? How do we set that up? So we've been doing education on that for the past 6 months, and we'll continue to do so and have that as like a standing agenda item in terms of our clinical development and our clinical education. So, for us, as Dr. Ryan said, we follow the science across the board here at Brightview. The clinical services are no exception to that. So what we do behind the door in a psychotherapy session is reflective of best practices when it comes to cognitive behavioral therapy interventions specific to treating patients with substance use disorder. And then broadly, we follow a harm reductionist approach to treatment. In other words, we do not act in a punitive manner towards patients for struggling with the condition for which they're seeking our help. We don't do that in any other area of healthcare, and we apply that same logic in addiction treatment, that we will work closely with patients and with other stakeholders on what the best intervention plan is for each patient, and what their needs are, and how can we respond to that, and how can others participate in meeting those needs. But it is typically a more complex scenario than just rotely responding to everyone with the same exact plan. And so, just like on the medical side of the house, as Dr. Ryan has shared with us, the same level of detail is used on the clinical side. And the great part is that those teams come together at every center every week for a multidisciplinary treatment team, which can frankly happen on the fly as well. But it happens on a structured, scheduled basis where everyone knows it's predictable, repeatable inside of a Brightview facility. So the teams have an opportunity to get together and coordinate their interventions in that structured way, in addition to anything that comes up on the fly as well. So a little bit more explanation about virtual care, but what I'll say here is that we don't really think about telehealth necessarily as being an innovation. Instead, we look at telehealth as being table stakes, the price of admission for being in the business of healthcare in 2020. I think the most complex version of that is certainly virtual group therapy. And so we do video visits and audio counseling on the clinical side and on the medical side as well. Virtual group therapy is obviously a significantly different beast, and we have done quite a bit of development, both again on the technology side several months back, and then also on the clinical side. So, if you are using technology more so today than you were 6 months ago, I can't imagine that you're not. Patients are doing the same, and we at Brightview are doing the same. And so that also includes online scheduling, where you can schedule on behalf of someone else as well. I know when I was in the hospital system, that was a frequent barrier, that we could not schedule on behalf of patients, and our online scheduling system allows you to do that. There's also a chat function online where you can talk to a Brightview person if you don't like to talk on the phone, as many of us do not like to do in the modern age. So last time I called Amazon for customer support, I didn't actually call them. So we seek to meet that level of customer service as well. I think I'll kick it over to Nate to talk a little bit more about the CJ reporting and what you guys can expect.
Great. Thank you, Dr. Kang, Dr. Ryan. So the heart of this conversation, you can see how we're adapting medically and clinically, both for this population. The criminal justice population is massively affected by the COVID virus that we currently have, and as we continue to adapt our services, but also think from a virtual platform, it is essential. Part of what we realize, regardless of what environment we're dealing with or a pandemic, is even pre, during, and hopefully not post, we realized at Brightview that we could do a lot better in how we manage our criminal justice patients. Not getting into the detail, but I was rightfully tasked to say, Nate, we need to go really figure this out, because we owe it to our patients, and we owe it to our partners in the criminal justice market to do a better job at co-treating, really what this is, right? You are treating them as well by providing them an opportunity to receive treatment potentially in lieu of conviction, or ensuring that if they're coming out of jail or prison, that they are doing well and stay out of that so they can move on with their life. So we set out on a robust process to understand what we could do from a treatment provider to be a better partner with our criminal justice partners in the community. And what we had determined, having reached out to many of you, and certainly engaged our clinical teams and our outreach teams who engage with you on often, and to figure out that we really came to the conclusion that communication and accountability were two of the main things that we needed to improve on, and are the drivers between providing a good and a high quality level of service to our criminal justice partners, primarily our courts, our probation and parole officers. So what we decided and what we identified is that the way we can do that is that we create a really consistent op-tempo in providing the information that you need about your parolee and probationers, who are our patients, so that you know what's going on and can make good decisions about what to do with them, and to work with us to ensure that we can do our part as well. What is not feasible is, or what is not efficient, is when you have to continuously ask Brightview or any other provider for information and continue to knock on our door, and I need to know this about Joe or Johnny or Susie. That's time consuming. It's certainly frustrating for you. And for us, it ends up creating a reactionary system that isn't efficient in how we run each one of our sites. So what we identify was a real sweet spot for our company, and for less for our company, actually more for all of you, is if we can get reports out every 2 weeks on the status of those that are involved in the criminal justice system, that on average, if not better than average, is going to meet your needs. Yes, we understand on a case-by-case scenario that there may be circumstances where that needs to be more frequent. We've even had some say, please stop sending me reports too often, but we would rather send more than less. So we have developed a cadence where we are automating the system. As Dr. Kang had alluded, we have a case management specialist team, and their whole job, and they are internal hires from our case management clinical team, so very well versed and certified in the clinical practices, who literally their responsibility is managing the reporting and accountability for the criminal justice patients that are in our system, and to provide accountability to all of you. And on top of that, they do all the reports, but even more so, they're also there to manage the relationships to, if there are any barriers or problems with service, they will be responsible for that. So we are scaling that throughout Ohio. It's a regionally based position. We anticipate having up 4 to 5 that will be covering the state of Ohio. That's on average 4 to 5 sites, depending on the density of our sites. And if you're in, working with Brightview and in the criminal justice market, you will certainly be working with those folks. And so far, it's been really exciting, and just seeing how well they're doing in the improvements that we've seen in our reporting and accountability and overall communication with all of our criminal justice partners. So it really comes down to getting the information that you need when you need it. It's that simple. It sounds like a commercial almost, but it's the truth, and that's what we found to be very, very important for us to do that. As we've gone through this process and have implemented it, we have 2 that are hired, so we're not at every site. So the work is, majority of the work is still owned from the case management teams at our Brightview locations, and they are certainly doing their best under Dr. Kang's direction to manage and follow the process that we put in place. But we soon hope to relieve all of them of that duty, and to have this CMS case management specialist position in place. So what we've identified so far, some learnings, and I look forward to your feedback and questions in the forum, that one of the main pain points that we have in order to make sure we can communicate with you is the release of information, is that ROI. It is often either not signed coming in the door if it's a referral, or we find that sometimes information is incorrectly filled out, or a patient is just not willing to sign it, and that creates a very frustrating barrier, particularly with probation and parole officers, when they can't get information on someone. They know that's at Brightview, but we cannot acknowledge it. So we've taken it upon ourselves to make that a clinical intervention, and I'm appreciative and thankful again for Dr. Kang to highlight that in the clinical team. It's not just about someone at the front desk when a patient comes in and says, here, sign this. It's let's have a discussion with you if you're involved in the criminal justice system, of why it's important for you to have a release of information, and why communicating to your probation, parole officer, or court is going to serve you well in your treatment and everything that you do post-treatment and during treatment, outside of treatment. So we are really making a robust effort to do that. And we track this internally in the company. We are to really divide our patients into 3 categories that we identify. We know that some come in as a referral, and that makes it easier for us because we know they're coming from your system. Oftentimes, a patient will be involved in the system later, or they come from we call those newly involved patients. And then we have those that we identify on day 1, but maybe referred from somewhere else, or maybe we're a walk-in, but also happen to be involved. I can be honest, talking to a lot of probation and parole officers, they do not care, and you do not care if you refer them to us or not. If they're at Brightview, you expect to be able to have that relationship and that information. So it's on us to make sure that we identify everybody that's involved in the criminal justice system. And for those, and by involved, what we mean is requiring accountability, requiring reports, and requiring that level of information. So that's how we've done it. Lastly, what I will say is it's an important part of us that we live in a digital world, and the digital world really helps us in this case. So the ROIs we prefer, we put a digital ROI and electronic ROI, I should say, on our website. All of our outreach managers like Amy and others will guide you to that, because it's really easy to fill out if you're referring to us, and you can't really make a mistake. And it also immediately goes right into our system. So as soon as it is sent, hit click, it is in the Brightview system, and we are ready to be able to add that patient to our reporting op tempo. We also have an online scheduling platform, and that's, we did that even before COVID, but it's even more, I think, beneficial with COVID. We really, really encourage people to use that. As Dr. Kang says, it's, very few people are making phone calls. Yes, we do have our call center, and that's one way to do it. Our patient access center can certainly do that, but our intake form is an easy way as well. So what we encourage is, if you're going to refer someone to us, is to leverage the resources that we have to do that, be familiar with them, and folks like Amy can certainly educate you on that and ensure that you have access to those resources. So our goal really is to identify every single patient throughout all of our Brightview locations, and we know Wilmington has a fair amount, that we are 100% with utilization on getting it with their reports, so that you have the information you need when you need it, and you never have to ask Brightview for it. That is our goal. And then within that, Amy will talk more about this, is the importance of feedback, because this whole process that we built around this criminal justice reporting network was based off of feedback. And we went through actually 5 iterations of our process to get it to where it is today. And we're continuing to and willing to adapt it based off of your feedback and what we can do better. So it's super important that we have that feedback. We're not experts in this. What we're trying to do is be as best an expert as we can be. And we just know that this is a top priority. I'll leave you at this. I don't think Dr. Ryan or Dr. Kang would disagree with me at all. This population is absolutely our top priority. Everyone's a priority, but it's a priority for us to get this right because of the relationships and the collaboration that's required for us to ensure that these folks not only just rescind out of the treatment, but do not rescind back into the criminal justice system. So we're really excited about what we're doing. We're not quite there yet. We're scaling rapidly. We hope to have all of our sites covered with a case management specialist by probably the mid-December. We want to get it done before the Christmas break. So I look forward to seeing your feedback and introducing our case management specialists to all of your community in Wilmington. And it's going to be, I think, the right thing to do. And we hope it provides you a level of service that you deserve and our patients deserve. So.
And just to kind of piggyback off what Nathan was saying, so actually quite a few of you have already met our case manager that is assigned to our reporting here at Wilmington. His name is Mo. So I definitely appreciate all the feedback that you have given me so far, just with his response and getting those reports to you in a timely manner. So just continue to work well with him. So as Nate mentioned, our NPS system. So this is a system that we do utilize to gather your feedback. It is a survey type system that goes out via email, typically after we've had some type of encounter or meeting. And so with that, it really just kind of goes over, how can Brightview become a better partner? What are we doing well? What could we be doing more of, or what could we be doing differently? And so with that feedback, the team takes that information and then implements that into best practices moving forward, also into developing programming. So as Nate mentioned, that's how today's forum came about, is really just taking some of the feedback that we've gotten from our partners and wanting more information or more understanding on the different services and ways that we interact with our CJ system. So thank you for that. And again, we'll just continue to provide that feedback, receive that feedback, and address your needs. So we'll go ahead and start opening up the chat. I know some of you may be shy to ask questions out loud. If not, you can definitely take yourself off mute and ask those questions. Or
Most important part of the forum right here, right, Amy? So,
right. This is where you get all the information you need while our experts are on the line. But I did actually have one come over via text on my phone, so I will ask that, actually two of them. So one came over regarding the Ohio START program, and Nate, I know you mentioned the reporting. So one of the concerns is that Ohio START requires weekly reports. And so they had asked what all information do we provide in our reports?
yeah, sure. So, yeah, I think maybe I mentioned it quickly, but at least I mentioned that there are exceptions, and we are aware we've run into those. What I end up asking is when we have those exceptions, at first I want to know is how, is it something that we could see at, not only Wilmington, but all of our sites? Because if we see, something where we have START program and folks are engaging, I want to make sure that all the other sites also have that so that we make something universal. But yeah, so we will, the bottom line is that there are circumstances that are require that people are held to given certain programs, and we will do whatever needs to be done to deliver on those needs. So when I talk about the biweekly process, that is a broad on average. That is our system. And within that, we know that there are certain programs that will make exceptions, and we will assess those as we can. And what I can assure you is because of folks like Amy and our case management team, is that they tend to identify those quickly and get that to me and others so that we know right away and can make sure that the team that we have is either available to do that, meaning the case management specialist like Mo, who's coming down at Wilmington, or if it's going to be done at the site level on some of those specific things. So the information that we provide is that, again, we've gone through several iterations on what we actually put in on our external report. And by all means, if we're missing something or if there's something you need, let us know, because we've adapted it and added more information based off of your feedback. We provide a full, of course, their level of care. We provide a detailed quantitative list of all of their, the amount of hours, the dosage hours that they have clinically and medically, their attendance record. Toxicology is included in that, as well as free text. There's a selection. Are they consistent, inconsistent, somewhat consistent, to extent, but there's a free text box for where the case management specialist will review the notes from a counselor or a case manager on the site to provide some context to how well they're doing, or if they're doing great, we'll put some specific things. So you'll see that in there as well. One thing that has come up is that toxicology is not intuitive to anyone out there. So what I recommend is if reading the report or understanding toxicology is a learning opportunity for folks to reach out to Amy, and we're happy to schedule a call to actually review these things and to how to read that and understand what's in that report as well. So we are certainly able to do that. So does that answer the question?
It does. Thank you. Another question that came up more from
Dr. Ryan, were you going to add to that? Yeah.
Yeah, sorry, Amy. I don't want to reinforce Nate's point. I think sometimes toxicology or drug testing is seen as fairly simple in regards to what the patient is or isn't doing, and I wish it was that easy. I've spent hundreds of hours, and there are entire medical board certifications in toxicology that teach you about that issue. And so that's why we do promote, reaching out and asking questions. There are very, very specific and scientific reasons that we do what we do, the way that we do it. And again, I wish it was, binary, or yes, they're doing fine, or no, they're not, but it's just not that simple. So to reinforce Nate's point, that's been a area of expertise for us, specifically me. I do speak on it, consult on it across the country for different payers and criminal justice settings. I wish we could, coordinate with our partners, a very kind of green light, red light situation, but it's just not that simple.
Another question regarding Suboxone. So stated that they feel sometimes providers take a long time to wean the individual off of a dosage. What is your take on how long of a period of time an individual should be on, or the period of time it should take to start that weaning process?
This is a great question, Amy. It really depends on the individual. So, just like any other chronic condition, there are certain types of patients. I'm sorry, my light keeps going on and off behind the screen here, but there are certain, patients with conditions that will be very short term. There'll be some that are medium term, and there'll be some that are very long term. But it's extraordinarily individual, and there's no cookbook or cookie cutter way to do it. I'll give you an example. I had two different patient kind of cases from that spectrum. I had a middle-aged guy, concrete business owner who hurt his back, got hooked on Percocet, but really hadn't had the magnitude of trauma and destruction and kind of the whole spiral down. We were able to catch him before all of that happened, where he was just kind of on that edge of losing his house and wife and stuff. And we were able to transition him to a medium dose of buprenorphine or Suboxone type product, and then wean him off in a matter of months. And he did quite well with that, with some good pain management, physical therapy, and whatnot. On the other end of that spectrum, we have people that are doing massive amounts of, high-grade fentanyl for years, injection-wise, also complicated by mental health and serious pain. And so that patient is going to take much longer, and it may be possible that a small dose of buprenorphine is what they're maintained on for quite some time. And this, again, is all based on the literature that we review and read, written papers on the topic. There just is not they should be off of it in 12 months or anything like that. This is, it's a complicated situation that you're addressing patients' medications. And that's the same thing for other medication types. If you think about diabetes as an example, we see a diabetic, you start them on metformin and or an insulin product, generally is kind of the first round of combo. You talk to them about their life changes, their lifestyle changes, dietary, exercise, very, very similar to addiction, where we have to wrap the holistic picture around the patient. By and large, not that many patients actually come off of all their medications for diabetes, and they don't do it very quickly. But our goal, of course, is to do that. Less is better. We call it's kind of a complicated name, but I call it a polypharmacy reduction strategy, meaning you don't want people on meds they don't need, long term. But I'm going to tell everyone on the call very explicitly, there will be patients that can take quite some time to get stabilized and get a lot of those things, and then transition, off the medication if possible. And there will be patients that will stay on the medications for life, just like with diabetes. And that's, of course, not the goal. It's not the goal with any disease state to have somebody on something forever. But you do what you can, and you treat the patient's condition as most appropriately without any external forces deciding for them. I'll give one other example. I have had cases where someone else, somebody's mom or whatever else, said, well, this person needs to come off of this. And that has never gone well. If this is not a collaborative, individual decision made on the patient's best interest between them and their medical and clinical team, that's not the right way to go about it. And so that's how we address it at Brightview.
Thank you, Dr. Ryan. Another question kind of surrounding that is about our standard dosage. So when starting a patient on Suboxone, is there a certain dosage that we start them on?
Yeah, so a great question again. There's been a pretty extensive research and evidence to look at when you're dealing with certain types of patients. Let's say we don't have an average patient. That's pretty hard to designate. But if you have patients, we have a lot of patients that have pretty high, serious injection use. We know by the research that the medication dosing for those patients needs to be between 12, 16, and even beyond that milligrams of a buprenorphine product. Of course, if it's Zubsolv, that's a different milligram dosage. It's conversion factor and all that other stuff. By and large, what I would say is I don't actually know entirely why people get hung up on this. Nobody really asks that question about your antiplatelet medication for your heart or your insulin dosage they do amongst the medical team, right? Like if somebody's on a super high dose of insulin or super high dose of high blood pressure medication, we ask that question, like, why are they on so much? But that's amongst, kind of medical team in regards to their specific physiology. And it's not about necessarily anybody else's input on, why they're on this, that, or the other. But I'll say, one more time, we look at the research. We are bound to do that both from an oath perspective as well as a medical legal perspective, because I'll be transparent. If a patient is on the wrong dose and the medical case demonstrates that the evidence that they should be maybe a bit lower, could be higher. If they demonstrate that they're not on the right dose and that patient has a fatal event, that is malpractice. And we can't, as qualified and competent medical practitioners, make decisions that are based on external forces and opinions of others. That's just, and I hope it's clear for folks. No one would, if you have another condition, you would never want your mom telling me how much insulin you should be on, right? That doesn't make any sense at all. And so we just ask that people understand we have spent a ton of time, resources, finances in building this team of addiction specialists so that these types of questions, and trust me when I tell you, we look at our dosing across our entire organization. We look at retention rates and dosing, everything that, all the outcomes related to that. We track it very specifically and educate our providers constantly on the lowest dose that is effective, but also effective, right? So it's got to be the right and most accurate one.
Perfect. Thank you.
I hope it made sense.
Are the same MAT meds used to treat both opioids and meth?
So interestingly, there is some research that shows buprenorphine can be somewhat effective in methamphetamine addiction. So I know meth is it's been a problem. I practiced for years. I was around when meth and bath salts and all that craziness first came through, that we remember most specifically the kind of the waves of those things. The meth didn't go away. It just got overtaken by the severity of the opioid crisis. And so there are, again, a holistic treatment plan defined by the medical provider and the clinical team. We use contingency management and other therapeutic interventions. We put all that together to address, methamphetamines. Again, there is some research that buprenorphine or Suboxone type products may be effective for methamphetamine use. It's not FDA approved for that, so it's an off-label use. So that means it requires someone, like me, who really understands methamphetamine addiction to decide that that's the case. We do know that some buprenorphine or methadone are what we call dopamine supporting or kind of reinforcing hormone supporting. I don't know how to put that. It's one of the hormones in the brain and the rest of the body that helps people to maintain a reasonable and functional level of happiness. We know that buprenorphine and methadone support those hormones, and there's a complex set of them. And that is also an issue in methamphetamine use. Unfortunately, methamphetamines actually drive that dopamine spike, which what we measure is so far as a severity of addiction marker, kind of a lot more complicated than that. But the severity of addiction marker is how high does it spike that dopamine? How much, quote, pleasure does that person, it's not really pleasure, but euphoria or whatever else, how much do they see from that dopamine spike? And methamphetamines are the worst of all drugs. That's why you see people acting wild about methamphetamines even more so than opioids, and kind of, acute methamphetamine toxicity can look like somebody is completely psychotic. And it's a very dangerous drug. We're hoping, we're working, actually, I'm personally on a panel with the FDA to look at more medications that could be efficacious for methamphetamine use that will become FDA approved. In the meantime, we have some research as to some other medications that can work, and we do utilize those. And those are in conjunction, again, with the holistic treatment model, delivering things we know that are evidence and research-based, like contingency management.
Amy, if I could just jump in, obviously not on the medical front, but this is a timely question because it was just asked of me less than an hour ago. I was on a call with the chief probation and one of the judges of Crawford County, and they were under the belief that opioids are long gone, and MAT it was the thing of the day, and it's moving in a different direction. And if agencies aren't prepared to work with methamphetamines, and they don't want to work with the agency. So I think, just kind of highlighting just a pitch here that no one has figured this out exactly, just like no one has figured out opioids, because it hits harder than you can respond to it, much like the pandemic with this virus did too. But I would say that we're certainly, I know Dr. Ryan and for a long time, and we've talked about the changing environment of patients, using methamphetamines. It has to do with the economics of how drug dealers and see the need and opportunity and demand. We see patients. I'm looking at a large data set. We do a lot of analytics at Brightview to understand that. And I'm reviewing a data set of 20,000 patients in mixed usage. And many of them don't know that methamphetamines also have fentanyl. And so it's a really complex thing. But what I know, and Dr. Ryan can certainly reaffirm, is that if it's in the addiction space, we take it upon ourselves to be leading experts to figure out what is the right way to treat this population. And we, although it's not asked of us, it's not an expectation of us, it's just an expectation of ourselves that we will figure out and intend to be the thought leaders in how to best serve the methamphetamine population. And there's just, as Dr. Ryan said, you know, it's somewhat new is how we apply the MAT model, but we are aware that it is a changing need, and any place we are maybe dealing with opioids at a mass level that could change. And we are there to change with it, because it's not about serving opioids or just alcoholics. It's about serving all of those who are suffering from addiction. It's the broader mission that we serve. So if there's any concern, I think that we look forward to diving into that, you know, deeply and see that as a need. So.
Thank you. Another question is in regards to our pregnancy clients. So do we start tapering them off their medications prior to delivery in the event that they will test positive with their child?
Sure. So the answer is no, Amy. In fact, the research shows that sometimes, because what we call a volume distribution, or the size of the body and the fluid in it, they actually often even need more through their pregnancy. There's been one research study that looked at tapering of pregnant women. I think this was out of Tennessee. So just to be clear, a few things. It is not recommended by any entity in the country, not the heads of OB, obstetrics, not the heads of addiction, not the heads of psychiatry. That is not a recommendation that should be followed. If you see it happening, that is malpractice. The issues in the one Tennessee study that were interesting, where they showed two things. One of which, the neonatal abstinence syndrome that everybody worries about, which can be very distressing to the baby, mom, and team. It is not affected by tapering. It's not better if you taper the mom off of medications. That's a fallacy, and it's a really complex understanding of the brain receptors. The other part of that is the only study that ever looked at tapering never followed the moms 3, 6, 12 months after the delivery. And the reason that's such a big problem, I'm sure a lot of people on the call have kids, I do, is that stress related to new babies, whether you got one or many, which a lot of moms do, in that 3-month is a very, very important and potential relapse period. So the worst case, which happens, is non-science-based tapering, and then the mom overdosing and potentially dying because of the stress of having a newborn, sleeplessness, hormonal postpartum depression, etc. And so very clearly that is not best practices, and we do not follow that. Now, does that mean we don't use things like Vivitrol in pregnancy? That, of course, we do. It was previously not recommended necessarily, but that was based on some weird studies that were long ago. So if a mom is, if I have had a patient, actually still doing very well, who was stable on Vivitrol, got pregnant, we did not take her off of that. Again, these are very complicated medical decisions that all we ask is that folks understand the amount of effort that we've put forth as an organization to understand what to do and promote best practices for our patients.
Thank you. Another question. Our judge fully supports Vivitrol. Is there one medication that serves or has a better outcome than the other?
It goes back to the individual patient again, Amy. There is not a medication for all patients. That is not true in the rest of the entirety of medicine. Period. End of story. You definitely don't want to put somebody on the wrong, I don't care, asthma medication or whatnot, because of a belief in a certain medication. There are a couple of factors to be more specific. We have a lot of patients on Vivitrol, and I've had personally several that have done very well. But there are some conditions around that patient that have to be the right ones. That has to be a pretty strong psychosocial support situation. There are also, to some extent, the criminal justice and probation supports that are real and can help a patient be, accountable to their program. Those can help a patient stay and do well on Vivitrol. Patients that don't do well on Vivitrol are those with very severe organic pain, meaning like tons of back surgeries and stuff like that, or those who are very severely depressed. Vivitrol can have a really negative impact on those patients. So we 100% understand the diversion concerns. Now that there's an injectable buprenorphine product, if that is what a probation or judge or whatever all sees is most appropriate because they're worried about diversion, we can abide and we can work with that as long as the patient's insurance and everything works with that. But the decisions need to be based on the patient's medical physiology and presentation, and with the considerations about diversion and other things being undertaken. And we completely understand that.
Perfect. Thank you, Dr. Ryan. So we are getting close to the hour mark. And if anybody else doesn't have any further questions, I do want to add, though, if you think of things afterwards, definitely feel free to reach out to me, and I will contact my leadership and get those questions addressed for you. So just a quick overview about Brightview. Here's some things that we had touched on. Again, one of the big pieces I always like to point out, which I know we did a great job at talking about today, is that online scheduling. It is one of our newer features. We have definitely seen a good success, especially coming from our probation team. They're able to schedule their clients right away with them in the office, and so they know when that first appointment is going to be. It also has that ROI, as Nate explained, attached to it. And so that way, if the client does not show up, then we already have that ROI in place and we can go ahead and start those conversations. However, if we do not have that ROI signed and you do call for information, you will hear us say that we cannot confirm or deny that patient is ours until we get that ROI signed. So again, thank you. More questions started coming up. So well, I hear you. Thank you. That's what I was looking for. The next slide. So again, just some more overviews of Brightview, just making ease of access greatly impacted for our patients so they can go ahead and get treated when and wherever they are ready to do so. So again, here is my contact information at the bottom for those that I have not had the opportunity to meet with yet. I look forward to meeting with you here in the near future. And again, feel free to give me a call. That is my direct phone number, or reach out via email. So thank you all for your time today, and I look forward to talking with you soon. Have a great afternoon.
Everyone. Appreciate it.
Thank you.